everyone, in today's video we are going to talk about mastitis, which is inflammation of the breast tissue. Though it can occur in both breasts, it usually occurs in just one. Mastitis is most common amongst breastfeeding women. Actually, 80% of cases occur in lactating women. It is likely to occur in the second or third postpartum week, but can occur at any time. So let's jump right in. Let's start by discussing the pathophysiology and etiologies of mastitis. Mastitis can be a result of plugged milk ducts, or it can be related to an infection. But we're going to start by talking about why milk ducts may become plugged. Milk ducts can become plugged for several reasons. There could be an obstruction in the milk duct due to an infrequent breastfeeding schedule or failure to switch breasts between feedings. So say for example, the woman is only using her left breast to feed. Milk will build up and pool in the right breast as a result of poor emptying. This built up milk will eventually begin to clump and clog the milk ducts. Another cause could be that the infant is breastfeeding poorly, or the woman may be wearing restrictive clothing that puts pressure on the breast, which decreases the flow of breast milk. Now let's talk about what mastitis is caused by an infectious agent or pathogen. Cracking of the nipple or areola is common in breastfeeding women. And I'm sure you all remember from fundamentals of nursing, any type of break in the skin can be an easy way for pathogens to enter and invade the body. And that is exactly what happens in this case. These cracks and fissures in the breast become a portal of entry for bacteria. Also, lactating breasts have a blood supply and duct system that helps the growth of bacteria. Staphylococcus aureus is the most causative agent for infectious mastitis, followed by Streptococcus agalactiae and Corynebacterium bovis. But mastitis can really be caused by any bacteria. Usually, a culture insensitivity test is done to determine the causative agent, but we'll talk more about that later. Now, where does the infectious agent come from? It could come from inadequate hand washing of the parent. The infant may be infected by microorganisms from someone that works in the nursery, or it could come from microorganisms on the mother's skin. Also, stasis of milk in the ducts could also lead to infection. So let's go over what symptoms the nurse would see in a patient with mastitis during the assessment. If mastitis is caused by an infectious agent, as we just discussed, the woman may have a low-grade fever or hyperthermia. The woman may also have flu-like symptoms, so there may be sneezing, runny nose, and fatigue. The woman may report feeling run down or weak. In general, the patient with mastitis may have breast pain and tenderness. The breast may be warm to the touch. The area of inflammation may be firm, swollen, or hard. The nurse may see cracks in the nipple or areola. Axillary lymph nodes may be enlarged. A breast abscess may be present if the mastitis hasn't been treated in a timely manner. Also, a hard lump may develop if the mastitis is caused by plugged milk ducts. Okay everyone, so let's talk about how mastitis is managed medically. In some cases, an imaging test or biopsy may be done just to rule out the possibility of breast cancer. A culture insensitivity test is done on the breast milk to identify which microorganism is causing the bacteria. Based on what the culture insensitivity results are, the patient may be prescribed antibiotics for 10 days, and that's if the mastitis is caused by an infection. Because again, the patient could have mastitis because their milk ducts are plugged. So always remember, medical management and nursing interventions can vary depending on the patient and the underlying cause. The patient is usually prescribed an antibiotic from the penicillin group, but the type of antibiotic the patient is prescribed can also depend on certain factors, such as allergies or bacterial resistance. So for example, if the patient has a penicillin allergy, the healthcare provider may prescribe erythromycin. Now let's say that the culture insensitivity results return, and it turns out that the agent causing the infection is resistant to penicillin. The healthcare provider would likely prescribe an oxacillin, a cephalosporin such as cefazolin, or vancomycin, which are all safe for breastfeeding women. Antipyretics may also be prescribed to break the fever. Analgesics may be prescribed for the pain. Usually ibuprofen is the analgesic of choice due to its anti-inflammatory properties. The patient may be prescribed a heating pad or warm compress. And lastly, the healthcare provider may also write the patient a referral to see a lactation consultant or a nurse specialist with training and experience in helping breastfeeding mothers. Now the fun part. What can we do as the nurse to care for the patient with mastitis? So first, you would want to obtain a full health history. This is an important step in learning about any allergies, including allergies to certain antibiotics. During this time, you could ask the mother open-ended questions about breastfeeding, as well as how she feels about having mastitis. You should also assess your patient's pain level to establish a baseline. A lot of women with mastitis report a burning sensation in the breast. You would collect the specimen of breast milk for the culture and sensitivity test. Now, once your patient starts ABT therapy, you would want to monitor for adverse effects. Common adverse effects of antibiotics include skin rash, diarrhea, upset stomach, nausea, as well as vaginal and oral infections. Assess vital signs, especially temperature, to monitor the effects of treatment. You'd want to do this every 4 hours. You'd also want to monitor the mother's white blood cell count. Her white blood cell count will eventually begin to decrease as she continues ABT therapy. You're going to want to keep the woman hydrated with non-caffeinated beverages. This will replace any fluid lost by her elevated temperature. Adequate hydration is also needed for the body to successfully fight off infection. If the child is present, observe the mother while breastfeeding. Mastitis caused by plugged milk ducts can heavily be influenced by incorrect breastfeeding methods. Apply a warm compress to the affected breasts every 2 to 4 hours to reduce inflammation, relieve pain, and provide comfort. You could also offer the mother a tepid sponge bath to provide comfort and reduce symptoms of hyperthermia. And again, always remember that nursing interventions should be individualized and specific to the patient that you are caring for. Now, majority of our nursing care is going to require patient teaching. If the mastitis is caused by plugged milk ducts, you are going to want to go over the process of latching with the mother. During this time, you can explain to the mother that different breastfeeding positions, such as the cradle hold, football hold, or the sideline position, can help the infant to latch on properly, leading to the letdown of milk. Incorrect positions can lead to cracking of the skin and improper emptying of the breasts. You can also review the importance of breastfeeding regularly. Explain to the mother that massaging the breasts before and during feedings may also decrease the chance of plugged milk ducts. Now, if the mastitis is infection related, you would teach the mother to take the antibiotics for the entire course. Talk to the mother about common side effects as well as adverse effects of the medication. Explain to the mother that she should wash her hands before touching her breast and that applying a medical grade ointment such as lanolin can treat sore, cracked nipples. Instruct her to wear a supportive bra but to avoid wearing a breast shield because this may trap moisture and lead to skin breakdown. You can teach the mother to apply warm soaks to the breasts or let warm water flow over her breasts in the shower. Teach the woman that mastitis doesn't affect her milk quality so she can continue to breastfeed. The prescribed antibiotics shouldn't affect the infant. Actually, according to the American Academy of Pediatrics, if an antibiotic can be administered directly to a premature infant or neonate, then it is safe for the mother to take the same antibiotic when breastfeeding. The most the antibiotic will do to the child is make them a little irritable, but in general, they should be safe. However, if the healthcare provider had to prescribe an antibiotic that is contraindicated to breastfeeding, teach the woman to still pump her breasts, but dump the breast milk. If she empties and dumps her breast milk, this will prevent milk from pooling around in the breast, leading to further discomfort and engorgement. It will also maintain lactation until the woman can resume breastfeeding. Instruct the mother that she should do this until ABT therapy is complete. During patient teaching, you could discuss with her some temporary alternatives to breastfeeding until she finishes her ABT therapy. And lastly, but certainly not least, encourage rest to promote healing. Okay everyone, that brings this video about mastitis to an end. Remember to never give up, and as always, thanks for watching.